So the opioid epidemic is finally reaching public attention because last year the Centers for Disease Control reported over 30,000 opioid-related deaths for the first time. So people are paying attention. This has been going on for a really, really, really long time. Let me tell you the reason. It's people like me, primary care physicians, that don't know what they're doing or don't understand the power of this drug. I had a patient who 2 weeks ago called me up. He had shoulder pain. I sent him to an orthopedist for his shoulder pain. He said, "Doc, you know you've been treating me for depression?" I said, "Yes." He says, "I found the cure. The orthopedist put me on Vicodin, and this drug has rid me of my depression. Can I have more of it?" That's the problem. And of course, everyone in the audience knows that in the vast majority of cases, one Vicodin isn't going to be enough. Then it's going to be 2, then it's going to be 3. Now, chiropractors are not the problem. As a matter of fact, 0% of chiropractors actually prescribe opioids. There's not a state in the United States where they're allowed to. New Mexico comes close, but no, you can't prescribe narcotics. That's a good thing. Us, primary care doctors, we're responsible for 28% of the problem. Let me tell you why. Because someone comes to us for back pain, and maybe we understand that the back is a tight compartment of muscle, nerve, and bone. But maybe we don't know which is causing the problem, muscle, nerve, or bone, or weight. How about the fact that the patient's overweight? So what does a primary care doctor do? They start trying to medicate to get the patient feeling better. And I call it the by-the-way prescription. The patient is being treated for a sore throat, and on the way out the door, they say, "Hey, doc, by the way, and can you refill my Percocet prescription?" Now, in New York State, that's being clamped down on in a really good way with a program called the iStop program, where literally I have to go online and spend about 20 minutes registering the patient, and there's a track record of that. And so the patients that go from doctor to doctor, that's being cut down on. That's not enough. It's got to be nationwide. And even then, that's only one piece of this. There's abusers, and there's a lot of news out of New Jersey over the last week. They're investigating over 30 doctors, one of whom is giving 6,000 prescriptions a month to patients he's never even seen. Another one has parents begging him to stop prescribing these medications because he's prescribing them to known drug addicts. In my opinion, doctors like that should lose their license, perhaps go to jail. The real problem is that this is only where it starts. It starts with prescription drugs, and then from there it goes to heroin. 4 out of 5 heroin abusers started with prescription drugs that they got from their doctor. Now again, I blamed primary care doctors, but I want to go a step further. It's not just primary care doctors. Here's how it goes. Somebody decides they're going to operate on a patient that may not even need surgery. Somebody has a disc. If you're a nail and you go to a hammer, you're going to get hammered, right? And I always like to say that a good surgeon is someone who knows when not to operate. Doesn't mean that all surgeons look at it that way. And there's some, and I don't want to be cynical here, but there's some sense that as things get tighter monetarily and you have to see more and more patients, maybe your judgment starts to be impaired. But I don't think that the pathway is right. In other words, you have somebody with back pain. Maybe they should be losing weight. Maybe they should be more active. How do they get to a surgeon? And how do they get on opioids? They shouldn't be on either one. Opioids are not a treatment for back pain. If the back pain is due to a muscular problem, muscle spasms are overlooked by us internists all the time. Now, how do I know about it? How come I can diagnose piriformis syndrome? How come I know sciatica? How come I understand radiculopathy? You know why? I'll tell you a secret. I'm married to a neurophysiologist. And I asked her this morning, she's triple boarded, I asked her this morning, what do you think of chiropractic? And I know the answer already. She says, they absolutely do no harm, period. She's a person who does not believe in neurosurgery and back surgery, except under extreme circumstances. And she uses chiropractors, and she uses acupuncture, and she uses physical therapy. She also is fine with muscle relaxants and heat, because sometimes it's a temporary problem. Muscle relaxants are a very underutilized treatment. Now, I know everyone out there is going to say, well, come on, muscle relaxants are probably overused because it's another throwing a pill at something, right? But they're a heck of a lot less dangerous than opioids. I mean, if you have a muscle spasm, what are you treating it for with essentially an addictive painkiller that can cause an overdose, can lead to heroin use. So I'm a fan of chiropractic. I think that there's a niche here, but again, the place to enter this is with the idea that we're getting a growing awareness of two things: the abuse of back surgery and the abuse of opioids. Since that's the case, and it's becoming a proven fact with more and more public awareness, we have to replace it with something. So let's replace it with things that work: heat, weight loss, exercise, physical therapy, acupuncture, chiropractic. We also need a much more of a national effort here, and I think that we're going to see that. Certainly, we saw a lot more money allocated in the Cures Act that was just passed, and we're going to see a real focus in this administration on the opioid epidemic. I mean, 70% of Vicodin use is not by people the drug was even intended for. It's medicine cabinet stuff. We all know the drugs we're talking about. Codeine, I mean, fentanyl abuse is really a disgrace because a lot of that is obtained illegally. That's tied in also with the heroin epidemic. There's a thrust on the part of the DEA to make all of these drugs Schedule II. I think that they should be. I think all narcotics should be Schedule II. The drug has a high potential for abuse. The drug has a currently accepted medical use and treatment in the United States or a currently accepted medical use with severe restrictions. Listen, this all started with cancer, right? I mean, people that are dying of cancer need relief any way they can. That's what opioids are for, period. Maybe they're for a few days after a very painful operation, but they're not for chronic use. The Institute of Medicine says that there's 100 million chronic pain sufferers in the United States. 100 million? Where did that number come from? I'm not even sure I believe in the term chronic pain. I like the term recurrent pain, not chronic pain. What is chronic pain? Recurrent pain means like atrial fibrillation. You got rid of it and it came back. Okay, I can understand that. But why not try to get rid of it in a way that is healthier than throwing a medication at it and becoming a self-justifying poor physician, for lack of a better word. And I have to tell you another secret. I am not a big user of pain specialists for this reason. I'm not against pain specialists, but you have to find one that isn't prescribing opioids all the time. So it's not just primary care doctors. Americans, constituting only 4.6% of the world's population, have been consuming 80% of the global opioid supply. How'd that happen if it wasn't for doctors like me? And by the way, just so that the FBI doesn't take me out of here, when I say doctors like me, I'm not talking about me. Not me personally. I don't fall for that by the way stuff. I won't do it. I'd rather have a dispute with the patient. I want to know why you're on that medication, who gave it to you, and what's the reason you're getting it. And then I will much sooner send that patient to an addiction psychiatrist than I will to perpetuate the addiction. It's a much deeper thought to try to get an alternative reality, or an alternative treatment, like physical therapy, like chiropractic, like acupuncture. And I'm very aware of the differences, by the way. I'm not getting into this in this talk. I'm aware that physical therapy may not last. I certainly know that back injections don't last. By the way, I would prefer an injection to opioid any day of the week. The problem is that they don't work most of the time either. The vast majority of the time, back injections don't work. If the patient insists on it and says it does work for them, then I will actually use it or send a patient for it. But that's not a place I start either. I try to say, what's the problem? Let's diagnose the problem. That's what doctors aren't doing enough, period, anymore. What's the problem? Is it muscular? Is it a disc? Is it stenosis? How severe is the problem? We have to figure out what it is and then treat it. Clearly, with a lumbar spine, we should be using chiropractors. There's 600 new laws pending out there, and that's not enough. 31 doctors are under investigation in New Jersey. I told you about the guy that prescribed thousands of prescriptions. In Maryland, Governor Hogan declared a state of emergency. You know, I interviewed Governor Hogan last year, and I find him to be very interesting because he himself suffered from lymphoma. and he was a patient, and he kept working as governor yet, and was getting his chemotherapy through his IV bag while working as governor. I think he's heroic, but he understands what patients are going through, because he was a patient himself for a long time. And I think that he's very sympathetic to this, and I'm very glad that he called a state of emergency. I think it's a public health emergency, period. And I think we need more and more addiction services. Of course, I haven't mentioned other medications that you could use for back pain. I don't want you to think that I want you to get the clear idea, and I think you are getting the idea, that I'm not a pill pusher. But before I would use opioids, I would consider the role of NSAIDs. Now, there's a problem with NSAIDs, which is that they can cause kidney and liver problems, and I don't really want, and stomach problems, and I don't want my patients on NSAIDs chronically, period. Almost every one of my patients that comes to me on a lot of NSAIDs, you know, Advil, Motrin, any of them, naproxen, patients love naproxen for back pain, the problem, or headaches. The problem is, it's not good for your kidneys, it's not good for your liver, and it's not good for your GI tract. So it can't be a solution. And alternating it with Tylenol, which a lot of doctors do, is a temporary solution also. Ultram works for some, Neurontin and Lyrica, they work for different reasons. Neurontin makes people sleepy, Lyrica makes people sleepy. If you ever had these medications, they're not long-term solutions either. In January 2015, the Joint Commission, the organization that accredits more than 20,000 healthcare systems in the U.S., recognized the value of non-drug approaches in the face of the U.S. opioid abuse epidemic by adding chiropractic and acupuncture to its pain management standard. And I've been saying I want the American Academy of Neurology to recognize this as well. I like neurologists, mainly because I'm married to one, but I like them for this. I like neurologists for this better than I like orthopedists for this, because an orthopod can actually operate on you if they feel you're not getting better. I like the three-step process. I like neurosurgeons, but for the right, a good neurosurgeon will tell you, okay, a patient came to me for a consultation, but I really can't make him better, or he's going to end up with a scar, or 5 years from now it's going to come back. There's purpose for neurosurgery, especially in the day of minimally invasive surgeries, but that is probably a second to opioid epidemic as a real problem that we've created here. We created this opioid epidemic because we believe in the concept of chronic pain, and we tried to medicate it away. Physicians and pharmacists and pharmaceutical companies have caused this problem. Now we have to solve it. The CDC guideline for prescribing opioids for chronic pain and the National Pain Strategy both encourage medical doctors to utilize non-pharmacologic conservative care and consider non-addictive alternative options, behavioral changes, and non-addictive pain relievers. Fine, that may be their guideline. My experience is guidelines don't matter. What matters is what you know and what your practice is. A primary care doctor faced with a patient with excruciating back pain doesn't know what to do. Half the time they miss the muscular part of it, and they don't prescribe muscle relaxants. They don't understand the role of a physical therapist properly. They don't even think of acupuncture or know anyone that does it, and they don't know a chiropractor to refer to because it's considered in another side, like alternative medicine, which it's not actually. So the goal is to build bridges, and I think that can be accomplished. And of course, there's also patient satisfaction. Large Medicare data sets reveal that more doctors of chiropractic and a higher level of Medicare payments for chiropractic manipulations, there were fewer patients taking opioid drugs. That's a huge piece of this. That if I send a patient to a chiropractor, they're much less likely to take an opioid. Chiropractic care in conjunction with standard medical care was found to offer a significant advantage for decreasing pain, improving physical functioning when compared with the only standard medical care for men and women between the ages of 18 and 35 with acute lower back pain. They're the highest rated healthcare practitioners for low back pain treatments, above physical therapists, specialized physicians, neurosurgeons, neurologists, orthopedic surgeons, and certainly primary care physicians. A study of upper cervical chiropractic care for neck pain, headache, mid-back, and low back pain concludes that 9.1 out of 10 patients indicate a very high level of satisfaction in the care they received. The only caveat I would add is I don't like an undiagnosed back. I want everyone, chiropractors included, to know what they're treating. We live in a society where we love our pills. It's an escalating problem. The amount of prescription opioids sold in the United States quadrupled between 1999 and 2011. In 2011, it was 7,200,000 milligrams were prescribed of painkillers. Who prescribes these meds? 28.8% primary care doctors, 14.6% internists like me, 7.7% orthopedic surgeons, 0% chiropractic physicians. We have to change how we manage pain, and I think we need teamwork to do this. I don't think it should be dueling practitioners. We need teamwork. I've worked at the Rusk Institute of Rehabilitation Medicine for many years. I've seen teamwork. I think that we have to incorporate chiropractic into the fold. This ruins lives. It kills people, it ruins lives. I think we're going to see more attention paid to this. We have to get more visibility here. I just end by telling you a story about a heroic nurse. She's called the Addiction Angel, and she practices in Staten Island. And she told me a story of a young man who was addicted to opioids and had had several overdoses. And then he had a child, and the child had a very severe medical problem where her intestines were outside of her body and she had to go through surgeries. And you know, caring for another person like that and having to put her life ahead of his cured him. And he got off of the opioids finally with the help of the Addiction Angel. And I think the message here is, it's not just about the mechanics of what we do, it's about what kind of healers we are and how much we care and how much we can get our patients to be motivated. Thank you.